Morning. Hello. Sorry, guys. We're running a little bit late, so I just want to get going so I don't hold you guys over. My name's Erin Horax. I'm a nurse from the Oregon Burn Center. I've been a nurse for 13 years, 11 have been at the Burn Center. And I am the outreach coordinator. I don't know if any of you guys have met Curtis Ryan along your ways in your career. I am the new Curtis. I look a little bit less like Santa, but I have a lot of information, I promise. So he was very sad to retire, but is well wishing me on my way into the community. So I'm a pretty casual presenter. Most of my time has been at the bedside and doing training hip to hip style at the bedside. So please just speak up if you have questions. It's way more comfortable for me when things get interactive instead of just standing up here and gabbing at you guys. We're off to a great start. Okay, great. So what we're going to talk about, we're going to just go over what the Burn Center team is like, what we do at the Burn Center, kind of our patient population, which you guys might have insight to as well, skin and burn assessment without going into anatomy and physiology and all that stuff, and then the primary and secondary assessment, airway management and fluid resuscitation, and then I'll show the transfer criteria for the Burn Center. So I like to show this map just to give the idea of how big our region is. So the red dots are all the American Burn Association verified burn centers. That means that we have all the programmatic pieces that make us a true program for burn patients instead of just a unit that happens to be able to care for burn patients. The closest to us is Harborview in Seattle and Davis in Sacramento below us. We'll get transfers from Alaska, Hawaii, all of that, but we cover a very big area. We are 16-bed unit, half is ICU beds, so we can do ventilators, the one-to-one nursing care, and then the other half is acute care, so that's either your walkie-talkie type of patients or people who have just moved from the ICU setting. And then we have a charge nurse that triages all the consult calls for the area. So every time an emergency department, an urgent care, a primary care doc, whoever calls, there's a charge nurse that answers the phone, and then they triage that. So they either give advice and move on, or we push that forward to our burn surgeons. And we just celebrated our 50-year anniversary. So what makes us a program is we have all this massive multidisciplinary team, and all of these people have had some extra exposure to burns. I have had 2 chaplains pass out and hit their head in an ICU room. You know, you call to help them or have them help tend to your family in distress, and then they walk in the room and faint themselves. So it's really important to have people have exposure to the burn patient population. The smells, the sounds, the visuals, all of that can be very affronting to people. So we want all the exposure we can get, and then all of these people have extra training. It's a really close-knit team, and a lot of people have been working there for a long time, so it feels like a family. So we admit about 400 patients a year, but every year it's gone up. So last year was 410 maybe. And we get about, last year we got 1,442 consult calls for our region. And then this year we're already, March? Yeah, we are well on our way to get way more consult calls than that. So that is a reason we are always full. And what we've noticed as a problem in our area is our transfers are getting more and more delayed. So if you are someone who has come across a patient and you're doing pre-hospital care for them or care for them in the emergency department, the amount of time that you guys are going to be holding on to that patient is longer. Because we are full, we're trying to make a bed. And then on top of that, a lot of these are long transports. So it's taking other transport availability away. So it feels like we're waiting in longer and longer lines, and patients are just not getting to us as fast as they used to. A third of our patients are children, and a majority of those are children under 5, and a majority of those are scald injuries. So injuries that are happening mostly in the kitchen. We have a lot of microwave related injuries, and I can talk on that in a little bit. And then the rest of our population, I can say data driven, is mostly male, and it is people putting something on something that shouldn't be happening, right? So an accelerant on something that's already burning, that type of thing. So, and then the other category that is not, sex dependent is our houseless population. And we are seeing a lot of people using heat sources that are not safe in a tent or something like that. And then that mixed with, the other crisis that's going on, mental health on top of fentanyl. So people are very heavily impaired, and if they are in danger due to a fire, they're not moving as quick as they should to remove themselves from that heat source. So patients can stay in the hospital anywhere from 2 days. Maybe they're admitted just to get some advice on wound care, and we make sure that they or a family member or a friend can do the dressing and then come back to us outpatient. Or the longest patient I've taken care of discharged a day before being with us for a year. So the scald category isn't just kids. This happens to everybody. But the youngest burn patient I have ever had was 6 weeks old, and it was just a tired mom trying to drink her coffee while she was breastfeeding, and her coffee spilled just a little bit and down on the cheek to the baby, and thankfully they were fine and were able to go home with no surgery. But these are just things people don't always think about. The grease fires are just, it turns into like a comedic clown act. It's very confusing how it happens, but how do we put out a grease fire? Not water is key, right? Well, now everybody can take a nap. Is that what's going to happen? So basically what happens is people panic, and I can tell you people, and you guys probably know based on your experience in the field, but people don't even stop, drop, and roll. That's something that we've been taught since we were kids, and everybody runs. Not everybody, a majority of people run. So basically there's a grease fire, people panic, and they either put water on it or they want to grab it to take it outside. So now they've touched the pan and maybe they have a contact burn from the pan. So then they start walking outside. It's on fire, so now their clothes are on fire. Now they can't really see, and they get to the doorway and they try to open the door and they trip a little bit, and now the grease has splashed on them. So now they have a contact burn, clothes on fire, a scald from the grease, and then on their way down they trip and then they break their femur or something. It is just this, and maybe that doesn't happen every time, and maybe I only see the patients that has happened to, but it's just a series of unfortunate events, and it turns into more of a trauma than just a burn injury. And then microwaves. We've been doing a lot of work at the American Burn Association to gather data to prove that microwaves maybe should be adapted a little bit to be a bit safer for our toddler population. We can trend that our independent, spicy toddlers that wants to get their cup of noodles, their mac and cheese, they've seen mom and dad do it a million times, and they go reach. And if I get a consult call, just very much like this picture, I have a good idea of what happened to this kiddo. And it's an innocent mistake. These poor parents are distraught that this happened. There's no neglect here. This is just a really independent toddler that wants to do their own thing. So instead of a microwave being a push button or a pull handle, could we argue it might be better if there's a 2-point mechanism? So maybe you push down with your thumb on a button and then pull. These are the things that we try to use all of our data and all of our trendable accidents to try to get change. These things take a really long time, and last I heard manufacturers, like the main 2 manufacturers for microwaves, it's still under review, right? And then that's not going to take out of use, we're not going to all go replace our microwaves, right? And so, but those are examples of things we're trying to improve with all the data that we collect. Bottle warmers. That's the best way. The immersion process is the best way to heat liquids. So baby formula or breast milk, it doesn't have those hidden pockets of heat that we can't control when you heat something in the microwave. But now bottle warmers, how hot do you think the water in the bottle warmer gets? It boils. It bubbles if you leave it on long enough. So now we were getting scalds to the poor parents that are trying to do the right thing and heat the bottles with the bottle warmers. And then cooking appliances. If you've bought a recent appliance, does it have a short cord or a long cord? Short, right? So that was changed because there was issues with fires starting, because if an appliance fell off the counter, it didn't come unplugged, and maybe that is a fire source. So now it's required to have a certain number of outlets. I think it's 2 feet off the corner and then 4 feet. Every 4 feet you have to have an outlet. Well, we still have islands, right? So there's outlets on our islands, and we have a lot of kids that are going by and pulling or touching cords, and that's the chili, the beans, all that stuff too that's extra viscous, and it doesn't just run off them. So water is the best thing to get scalded with if you're gonna get scalded. But the other stuff stays a little bit too long. So try not to have cords out and about. We get a lot of those. And then shower and bath. Why have we always been taught to observe kids in the bath? Drowning, right? Well, the other issue is scald. So there was I'll just stand by the computer. This is great. We'll fix it. Great. Can you guys see me behind here? Okay. So there was this study done in the 1940s, which is comical because it would never get approved now. Basically, a bunch of medical residents got burned at different varying degrees to see how long it took to get a burn injury. Yeah, I don't know. Like, let's hope they got paid. I don't know. But clearly, this has not been redone. This is data from the 1940 study. This has not changed. But it's a simple concept, right? So the hotter the liquid and the longer amount of time, you're going to get a burn injury. And the hotter the liquid, the faster it happens. So aside from just kids, we get someone maybe with a seizure disorder, maybe someone who had a mobility issue. So maybe they slipped and fell and couldn't get off or get up off the floor of the shower. So what do you guys think your water heaters are set at? Yeah, right? Yeah. Well, I'm one of those women that likes to like scald themselves in the shower. So it's been very hard for me after I worked at the burn center to lower this because I actually wanted it warmer. So that means though that a lot of us probably have it at about 124. So if you fall and you can't get up, or an elderly population, or someone had a syncopal event, or all of the things, it doesn't take that long to get a scald injury from that. Okay, so these are all the fun stories that I'm sure you guys have tall tales just like I do, but every time I think I've seen it all, something else happens. But these are a lot of the injuries that we see. So people putting an accelerant on something, we get a lot of really sweet gentlemen that have been doing their burn piles on their property for so long, and they think they're doing it the right way. They're not using, the flame is not already going. They aren't using like the lighter fluid bottle with the stream. They said, hey, I had it in a styrofoam cup and I don't take it with me. I just leave it there. It's people who are taking steps to think that it is a safer thing, but the amount of burn pile injuries or burning trash or brush or any campfire scenario, we get a lot of those. And it's because of the fumes, right? We can't control where those fumes go. So even if you put an appropriate amount of accelerant on a fire burn pile that you're about to get going, and then you walk away, and then maybe you're doing something where you're seeing if your lighter starts or whatever, that plume of fumes maybe has followed you. So sometimes it's not even the pile that's getting you going. And then what has become legal that everybody in Oregon is loving these days? Yeah, everybody has, enjoyed the Little Mary Jane a little bit more than previously. And now people are wanting to make their own hash oil, and butane is used to do that. And butane is heavy. We have seen, I don't know what your guys' experience has been, but we have seen like multiple apartment units taken down by a butane hash oil explosion. And then gasoline as a cleaning agent. I go and teach to the electrical apprentices in their school, and one of the instructors says that he used to help his dad. He was a mechanic and used to help him, and at the end of the day, he would wash his hands in gasoline because it's the best thing to get the grease off, right? So hopefully with more education and stuff, these things can be improved on. But when people have been doing things the same way for so long, we have such a large amount of rural communities, and people are doing things the way they've done them for a long time, and they work. And so these things just keep happening. And then I kind of touched upon the amount of, we're right in Portland, we're in Northeast, so we just have such a large homeless population that are getting injured from inappropriate heat sources or warming themselves too close to a fire and being so, the clicker. I abandoned the clicker. Oh, did it just catch up? I'm just going to stand here by the keyboard. It seems safer. So that's just a challenging one, but this also is the same as, like the person that was camping and they got so drunk they fell asleep near the fire and just didn't wake up right away, right? So these are stories that we see quite a bit. And then the smoking on oxygen. The Oregon State Fire Marshal is trying to come out with some more education to give to EMTs, firefighters, paramedics, all the departments to kind of distribute again. But sometimes we even have repeat offenders of the smoking on oxygen. I'll be like, this looks like a familiar name when I get the consult call and I look it up in our system, and I was like, yes. And some of those even happen in nursing homes. So I'm like, I don't know what party of a place this nursing home is, but they let you smoke, so I bet everybody wants to go there. But that has happened as well. And then some of our more severe injuries come from places that people cannot extricate from. So pinned in cars or pinned in a structure fire, those end up being really deep burns. Everybody with me so far? We're all good? So reminders of what the skin does for us: keeps the bugs out, right? Keeps us protected from infection, and it keeps our fluids in. We not only want our fluids in, we want our fluids in the right vasculature so that we can keep our organs perfused. And then it regulates our body temperature. So those first three things are essential to life, and people forget that the skin is an organ too. Obviously, when we do our ABCs, the skin isn't listed. I totally get that. We're appropriately doing ABCs if we're not thinking about the skin. We need to do those things first. But if these things aren't corrected and you have a big enough burn, none of that other stuff will matter anyway, because you will die from the impairment you have to your skin. So it also excretes body waste. Our patients often have damage to their sweat glands. So if we are doing some burn survivor activity down the road with a patient or that is now discharged and into the world, I go rafting on the road with some of our burn survivors, and when it's 100 degrees, they cannot sweat like they should. So they're just sitting in the water, when we're having lunch and stuff. And then it produces vitamin D. None of us have that in the Northwest anyway, so that's okay. And then it serves as a sensory organ, right? So people are thinking it would be really annoying to have numbness and tingling or an extremity that you can't really feel, but that actually impacts our activities of daily living. So if I go to pick something up, it's that sensory that tells me how hard to touch to be able to pick something. So that's a lot more than just the annoyance of not being able to feel something. And then our identity. This is big. What is the industry that has made millions, and there's some really fancy doctors that just focus on one thing and they make so much money, right? So if you have a facial injury, your ears and your nose are made out of cartilage. Those are the first things that are like severely permanently impacted as far as changing your facial structure. So if there's a whole industry out there for people just kind of making minor tweaks to their nose and the shape and how it looks, imagine if you lost your nose. These are big life altering injuries for patients.
She looks at you like.
So just a reminder of the skin as we go through the pictures in the next few slides. I just really like to show people the layers and remind people kind of how much right here is in the dermis. That is a bunch of important stuff. Our nerve endings, our capillary beds, vasculature, hair follicles, sweat glands. That is a very high real estate area. So when you get injured just past the epidermis, which is not that deep, you are already interfering with a big portion of the function of our skin. We are always going to know what you're talking about if we get a consult call and it's first, second, third, or fourth degree. We know what people are talking about. These are the fancy names that the American Burn Association has come up with, and these have been in textbooks for quite a few years now, but it is very common for all of us to still speak in first, second, and third degree. I would never, a surgeon calls me from an emergency department, a trauma surgeon, I'm not going to be like, don't you mean deep partial thickness? Like, obviously, I'm going to just, I know what they mean by third degree.
I know. All the time.
And then factors that determine how deep a burn is, and that would be how hot, how long, and then what happens to extremities that have poor blood supply? What are we worried about? Perfusion, oxygenation, so cells are dying to that area already. So if you already have like a poorly vascularized extremity, maybe you're a diabetic and you already have some issues with that and you're doing a foot soak and you don't realize you scalded your feet from your foot soak. Those burns are going to be way worse on those feet because they're already poorly perfused. So if you're starting behind, those are going to be way worse if your blood supply is already poor there. And then the thickness of your dermis. So our little kiddos and our geriatric population are at higher risk for a deeper burn. Okay, so rule of nines is what everybody learned about. I remember learning about it in school and like doing all these scenarios and practicing the math for my tests and blah, blah, blah. And then I actually get hired at the burn center and have never calculated a TBSA with the rule of nines ever. And it's because people don't get burned like, okay, I perfectly burned this leg and then half of this leg. That's just, no one needs to be doing math. We are trying to do our ABCs and keep people alive. We don't need to be doing formulas at the bedside to figure out the TBSA. So this is important because that testing wise is crucial. This is what we use at the bedside. So we'll have, our surgeons, our attendings do this too. It is the patient's palm. That is the key piece. That accommodates for the 6'7" basketball player that can palm, a basketball. That is his palm on his body equaling 1%. And then it helps because do you think everybody is just that size or that size? No. So it's the whole hand up to the fingers. It's not just the palm. So if we like to keep things as fun as possible at the burn center. So if a patient comes in, we like to guess the TBSA and see who can get closer. And I can tell you, none of us are doing math with the rule of nines at the bedside. So pictures are starting to come. I have learned over the years that you start to kind of get numb to things that you see, which like, who knows what that's doing to us long run, right? But I do want to be mindful and really point out, I have the luxury of seeing all these patients in a controlled environment. I see them on a mostly clean bed until it gets dirty by them. But my environment, it starts controlled and it starts clean, and these things are still really hard to see. So I have an extra respect for people that have to go and actually see where these people are coming from. When I have a family come in from a structure fire, I don't have to see that kid's poster that was next to the bed that kid got pulled from. I'm seeing a patient who I still think of as a human because I am a compassionate person, but it is a lot more controlled, and I get to go about my day in the comfort of my workplace. So I have an extra set of respect for everybody who's seeing these patients in the scene and on the scene, in their homes, in their cars, whatever. That has to be way more impactful. So pictures are coming. If they bother you, look away, walk out, whatever. You can't offend me. I just wanted to give a heads up that a lot of pictures are coming, and I don't want that to be triggering for anybody who has seen those horrific things that, you know, we have ingrained into our minds for so long. So superficial. The key piece I want you guys to know on this is that it's not calculated into the total body surface area. So sometimes we get a call saying, hey, we have a 70% burn, and by the time they upload pictures, I'm realizing it's 30%. They weren't wrong to say that they have had a burn to 70% of their body, but that is not calculated into the TBSA because this does not need any type of resuscitation or extra care like that. So if you calculated someone as 70% because you were calculating the superficial portion, you're going to be over resuscitating that patient. So a lot of times that bright red, blanchable, these are your bad sunburns that hurt really bad because what's intact? Nerve endings, right? So these hurt really bad. Patients get, you know, ibuprofen, Tylenol. They should heal on their own in 5 to 10 days. But the key piece that I want you guys to take away here is that it is not calculated into the total body surface area. Partial thickness, so that's that epidermis, and now we're kind of going into that dermis. These are still going to be bright red and blanchable. The other theme I want to be absorbed now is that to touch these patients, touch the burn. I know I have had a lot of firefighters say that like nothing felt worse than when you try to pull the patient out and the patient doesn't come, but the skin does. So you are not damaging anything extra. That happened before you got there. You just happened to be the body that the skin landed on, is the way I'm trying to say it. And even in, you know, when I go see a patient in the emergency department, sometimes the patient hasn't been turned yet because people don't know where to touch them. All the damage that's there, as long as you're not ripping and peeling skin, which no one's doing, any damage that happens from you touching, moving, mobilizing, doing anything like that, even tape that comes off. If skin comes off, that was skin that was already damaged. And then you know a lot more about a burn when you touch it. So if something is very bright pink and then you touch it and it's blanchable, you know all those capillary beds, all that stuff is intact. So everybody has different skin tones, and it's very helpful to touch. So these patients aren't gonna necessarily need transfer unless this is like over their entire bodies, or if there's more trauma involved. But they should be able to heal on their own in about 7 to 14 days and won't need surgery. This is another example of that depth. This gal was just minding her own business, trying to make mashed potatoes. She chopped it all up and then used the cutting board and the knife to slide it into the boiling water, got a splash to the face. This guy was trying to light the propane barbecue, which, you know, you hear the tick, 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 and you're like, oh, what's going on? And then naturally we all, I don't know what's going on there. So I was just at a rental house, and it was a group of moms. We were like happy to get away, drinking a lot of wine, and they're like, let's start the fire pit. And I was like, sure, I'll be over here, and you just let me know what you need. Like, there's no way I'm gonna be anywhere near that situation. And for sure, tick, tick, tick. And I'm like, it's not starting. But so he had time to do one of these motions, and he was in a tank top, and that's how his armpit got burned. Deep partial thickness. So now this is what I want to reiterate, the importance of touch for your assessment. So palpation. So there are different color hues here in this injury. This is all nice and bright red. It's dark, so you guys can kind of see that, right? And then there's areas here that are lighter. So that's telling me that that is actually deeper because those capillary beds are damaged. But when it's close to the patient's actual skin tone, people don't think of that actually being a deeper area. And that's what confuses people about, and patients themselves when they get burned. They think if it doesn't hurt, maybe it's not that bad. But if it doesn't hurt, those nerve endings are damaged. So it's probably deeper. And then if it's not that like bright, fiery red, patients seem to think it's not that bad, but that is the opposite. And so our really shallow, bright red burns are so painful and people think they're dying. And then the deeper you go, sometimes it's really actually having the opposite experience on those patients. So these patients are often going to be transferred to us. And if they're not, it's because it's small enough that we think that they can manage at home and it's not going to interfere with their systemic regulatory system. So basically, as long as it's maybe under 20% and we think they're like they have a clean place to go, you know, our homeless population, it's very hard to discharge with dressings like, hey, do this daily. If you don't have running water, you know, or a lot of patients live in their trailers in rural areas, and then we find out like the day before discharge that that trailer doesn't have electricity and it doesn't have a water hookup. So we really need a clean environment for patients to go. These dressing changes are going to start to get pretty painful. So maybe once it's dressed, you can kind of get by with Tylenol and ibuprofen. But when we start doing dressing changes on this, this would also be a reason that patients might have to stay with us even if they don't need surgery, because this is when we're getting out the oxycodone, Dilaudid, fentanyl, Versed. For pain, we have done a lot of really cool stuff in the last couple years. We now have just the Oculus goggles. So easy to have for patients. We did a research study a while ago proving that virtual reality as a distraction tool can decrease the amount of narcotics and benzos we have to use at the bedside. And that started with like kind of the same vibe of like if you had a substitute teacher and they like wheeled in that massive TV cart with the VCR. That was like our first virtual reality thing. But now, gosh, you can go to freaking Target, Amazon, and buy the cool headset, and it's really great for our pediatric population and our adults. We also started using nitrous, and that has really cut down on narcotics and benzos as well, and it makes for a little bit more of an entertaining dressing change as well.
You guys use the nitrous nose piece like a dentist, or do you use the green darts?
They have to hold on to it. And from a nursing perspective, it's like a dream because they can't over sedate themselves because they let go, right? So if they can hold the mouthpiece, we do that. And if there's a mask, we can't be assisting to keep it on in any way. But it's just the best because we're not Narcaning people. We're not like accidentally over sedating and having them need to be intubated. There's a lot of pros to nitrous, and we're slowly with a study trying to get that on board hospital-wide too. This is another example of that depth, and I just wanted to show the color variance, right? So if you touched the lighter area, that is going to be more firm because the edema is kind of headed to that area. And then in the bright red blanchable area, it's still going to be nice and soft. And then as things start to dry out, it means everything has burned to the depth that there isn't even a way for things to excrete out as much. So things are going to start to get tight and dry the deeper things go. Next picture, heads up. Okay, so this was a really nice guy. He's doing great. I like to start by saying that. He was doing a brush pile and just went wrong. His clothes caught on fire. Yeah, what can you guys tell here? There was something like that, probably cool guy, yeah. And this is when people on the job, I know if you were wearing your PPE, like I have a good idea. If you had your safety goggles on, you should have a goggle line on. We have a pretty good idea if you were wearing your PPE. But so these patients, this is crusty, flaky, firm, does feel like a leather purse. And this patient was with us for about 5.5 months, multiple surgeries. They use our whole team, and they will be ventilated for quite some time because we're taking them to surgery like every 3 to 5 days, usually. But very light in color, right? So not that bright red, scary burn idea, but way deeper. I like to show this guy. He was 23 and a chef in a kitchen, and he backed up and just caught his jacket on, on the stove, caught his jacket on fire. But this guy was so convinced. I went and saw him in the emergency department. He was over at our hospital, and he had a concert to go to the next day. And it'd be a way better story if I remembered who it was, and I don't. But basically, this is an example of he did not think he was that badly burnt. And he probably has a high pain tolerance, right? Because all that bright red in the surrounding areas, that probably hurts really bad, to be honest. But it wasn't, we take pictures to track our progress in wounds. So I had our picture camera, and I was like, and he was like, what? That's my back? And I'm like, yeah. Not only are you not going home to get ready for your concert tomorrow, you're going to be you need surgery. Like, you're stuck with us. Surgery buys you a minimum of 5 days with us. So that's just a perfect example of if it's deep enough and those nerve endings are damaged, they're not going to feel that as much. And then this is an example of a full thickness burn that isn't going to come to us. This was the only place that was burned, and so that's not affecting him systemically, right? And that is full thickness, but that burning process has stopped. So sending him home, it's not like he's going to continue burning. It probably doesn't hurt that bad. I bet it hurts on the edges, but otherwise, if he can have proper wound care, he'd be better off at home, and then he can come back to us for surgery when we're at that point. And that was from an arc flash, so an electrical injury, and his body didn't receive current, so he was safe to go home. And then I did want to just show that example of the degloving. So if you're ever removing someone from anywhere that any scene scenario, and you grab someone's hand, whatever skin is left in your hands is nothing that you guys did. That was already like that. So just the amount of trauma I've had with conversations with people from those memories kind of being burned into their mind. So I just wanted to show that's the hand of the guy from the previous picture. Am I good on time? Yeah. How much time do I have? Okay. Okay. So this is your got pinned in the car and can't get out. And these are those cases that you remember, right? Like when the mom showed up to see her kid, this was a 16-year-old. I'm going to hear that scream forever. You guys very much so are exposed to the same stuff. So this is not Burn Center or Legacy, but this is just me from my experience. We have become numb to this stuff because to do well at your job, you can't be affected by this in the moment. But are any of us actually processing this? No, we like meet our friends at drinks after work, or we head to the family barbecue, or we show up on Christmas Eve, or like whatever you're doing, and you're not processing any of this. And then down the line, what is that doing? I thankfully have gotten the privilege to talk on this about kind of how we're reworking our stress response. We're rewiring ourselves, our stress response, and even the way we like store information in our brains, because we are pushing past these things to be really good at our job, right? So I get to talk about that at the national conference this year, but there's not really a solution, right? Like a perfect solution. I'm not claiming to have one, but I think the conversation should be there on how we can better take care of our people who are taking care of these people, because we are essential to our healthcare system. We are, the huge, if you took away all patient-facing individuals, we wouldn't have a healthcare system. So really important stuff. It's okay to not be okay. And we're trying to figure out better ways to care for all the people who are having to care for these patients, because this should be an unsettling picture. It should be. And if it's not, it's a bit of a reminder that, have I gotten that black and cold and like inside? And we laugh about that, right? But what is that doing to us down the road? We want to do these careers for a long time, but like in nursing, you don't have those ICU nurses who have been at the bedside for 40 years anymore. Those nurses have retired, and the new generation is not lasting that long. People are done and moving to clinics and lower acuity environments quickly. How much time? 15 left. Thank you. Okay, so I just wanted to throw this picture in here to just show the difference of what a burn looks like on someone with a different skin tone. So our melanocytes, which give us our skin color, are in that more superficial layer, that it's in the bottom of the dermis, so bottom of the epidermis, right before you go into the dermis. So this is a Black man who was in an apartment fire, but once it gets burned, it starts to look just the same because the melanocytes, that area is damaged. But this in why I say touching the burn is so important, because this could be confused for like intact, hopefully if you're looking at this, you know it's not intact skin. But touching this is firm and crispy versus this is his intact skin. So we just can't do color alone. Not all of us have the same skin tone. And it changes as we get burned at various steps. Mechanisms of burns. I think you guys have seen a lot of these. I have 15 minutes left, so I have an electrical section and then airway and fluid resuscitation. I am going to kind of cruise through some of this so I can get you guys to the good stuff. So current injuries, there's two types of electrical injuries. You can be in the middle of an arc flash, meaning you did not receive current, you just got exposed to the current trying to go from A to B. That is hot and fast. It is so fast that you can't do what the propane barbecue guy did and put his arm up. That is happening well before you can do anything. And the arc flashes can get as high as like hotter than the surface of the sun, so super high heat. And it only takes 480 volts to be blown by an arc flash, and there's 480 volts all around us all the time. But current injuries are, you don't see what's all going on. There's damages to muscles and organs, and so there's a lot of hidden stuff happening. This is the arc flash I just kind of talked about here. There's not an entrance or an exit with this because the current didn't enter the body, and what you see is what you get. This is an example of an electrical injury of a lineman. This guy's doing well, by the way. So he already has some contractures from that voltage entering his body there at the wrist. And then we try to take these patients to the OR very quickly to make sure we can really gather how much damage there is. And that was his arm 4 hours later after the injury in surgery. We try to do as much wound care as we can for these patients, but sometimes you're better off with an amputation. He's got 3 prosthetics. He's got a hook for working on the farm, a robot-ish hand for a date night, he says. And then he has like a flesh-looking one that he likes to have for pictures and stuff. But he's way better off with amputation and the appropriate prosthetics than kind of, even if we could save that hand, a non-functioning extremity is just better off amputated. And then the key piece to remember with electrical injuries is the hidden damage also affects your brain. So patients that have had a shock, maybe they don't really have external damage, or maybe, you know, you're working on your house on the weekend. If you get a shock, there are things that can happen. You don't know where that current went. And this kind of looks like a stroke, but a lot of these things, when we're teaching to the electrical industry, I'm like, all of these things would interfere with you from doing your job. So if you get shocked, even if it's just a little zap, it's worth going to get checked out. Telemetry, a 12 lead, and a neuro assessment. Chemical burns, I don't harp on this very much. This is not a picture that I use pictures of patients I've taken care of. This is not a patient I took care of. This is from our textbook. But basically the most chemical stuff we see is on the job working at facilities, and people are getting into those decon showers so well that I'm not really seeing a lot of this. This was a kid playing with Drano in a laundry room unattended. And then we get people drinking things like lye, or we'll have, back when bleach was promoted as something that could kill COVID, we had multiple calls from people drinking bleach. So yeah, key is follow your decon protocols and protect yourself with chemical burns. Okay. So this is your primary assessment. You guys know this. I don't also want to be held liable for this being what you guys do in the field. Follow your protocols and whatever your primary assessment entails, but I just like to review some of the burn specific stuff. So this is obviously, like I said, please do not hold me liable, but these are things that I am thinking about if EMS transport's calling me asking about something, or if the emergency department is calling me, these are the things I'm thinking of. And intubation, this is a tricky one because I'm not in the field and I'm not the one that is worried about, am I going to lose this airway in this moment, right? So I'm just here to remind that a burn injury does not necessarily immediately mean intubation. But I will never fault someone for making the decision to intubate because that is your choice off of your protocols and you're the one in that situation. Our patients do better when they're not intubated because we can clear and move our own secretions so much better than when you get ventilated. And when you get ventilated, then you're getting all those meds on board. It's a whole grab bag of other stuff that comes with being intubated. So it's really assess the patient beyond, do they just have singed facial hair, right? Like assess to see if in a different scenario, would they warrant intubation? So I'm not saying don't intubate your burn patients. Please, please don't go and say, Erin from the burn center told us not to intubate. That's not what I mean. I just mean it's worth considering before you intubate to make sure the patient is actually in a distress state that they need to be intubated. Breathing, some of those burns you saw today had torso burns. That does interfere with ventilation. So at some point they need escharotomies to allow that movement to happen again. Circulation, what I want you guys to take away from that is that put access anywhere. We do not care if it's through burn tissue. Obviously, if you have an arm that's burned and an arm that's not burned, please choose the not burned arm. But then the other piece is even if you gain good access on the scene, the swelling can happen so fast that they might have edema that has removed that IV site while you're in your rig on the way to the hospital. Or often we have IOs. By the time the patient gets to us, that IO has just, the swelling has lifted it right out of the bone. So access needs to be monitored frequently. And then if there's a circumferential injury, we want pulse checks. We need to know that that extremity might need escharotomies. And then disability. Burn patients, the burn injury is not a reason to be unconscious. So we need to look at the bigger picture. You know, we'll have someone that was camping and they ran 3 miles to get help with like a 60% burn. Crazy stuff. The burn injury actually isn't what is making you unconscious. So if you are unconscious, we need to be looking for all the things you normally would in your primary assessment. And then for exposure, can we stop the burning? Hopefully, while you're simultaneously doing all this stuff, you're assessing the scene and seeing what can be done. And then remove jewelry as soon as possible. We say jewelry even before clothes so that those things with all the swelling. Rings now are not just made out of things we can cut. You guys all know that, cut with ring cutters anymore. So I'm not gonna show up to like a tungsten ring with a sledgehammer. I probably can't even like appropriately swing a sledgehammer. So like 5 minutes. Okay. So the secondary assessment, this is where we kind of get more specific, right? So we are trying to learn more about the mechanism. The mechanism matters. We treat different mechanisms a little bit differently when it comes to fluids. And then we want to try to get a pre-injury weight estimation. They start to get so heavy once all those fluids get put on board for them. And then, you know, we're trying to get a rough TBSA and depth, but if you're doing the right thing and getting them to the right place, and that place is consulting us early, the secondary assessment is kind of done remotely by us. ICE, what does ICE do to our vasculature? Right, so if I've had someone say, oh, I've got someone with bilateral hand burns, and then there's a picture and the patient's hands are in a bucket of ice, that burn is deeper. And I can tell you, because we're vasoconstricting, we're not letting the body do what, it's like combining frostbite with the burn. Like ice, no ice ever. And then cooling, there is an initial cooling period of 5 minutes. So if you get to someone, the burning process can be slowed with 5 minutes of cooling. But beyond that, you're putting them at risk for hypothermia or vasoconstriction. So we prefer them warm, clean, and dry. So I'm going to kind of cruise over this. This is me just reminding you guys, please actually assess if they need to be intubated. Don't let the fact that they have a burn injury be your indication for intubation. Unless if their burn is so heavily on the face, that is when we're worried about swelling to lose that airway. So those patients do need early intubation, and you can see that by, they probably aren't going to be able to make much sounds. There's damage to their vocal cords, and you'll see the swelling kind of start right away. And then below the glottis is all of our inhalation injuries, and those patients do end up needing ventilation for quite some time with us. And then pediatrics, just remember, if that tube gets bumped even a little bit, it can be out. Some of my scariest moments as a nurse is, trying to respond to a desatting vented kid, and you're like, what has gone on? Did we lose the tube? That kind of thing. Carbon monoxide poisoning, we get this every time there's a cold spell. So basically, people are bringing stuff into their homes to try to keep warm, or if there's power outages. And then those things put off carbon monoxide, and maybe their monitors in their house are not picking that up. So, that's the whole family goes to sleep and then they don't wake up. So in Portland, we did have one family that happened to with this last ice storm, but the neighbors found them and they were able to get into a hyperbaric chamber and reoxygenated. Yeah. Mm-hmm. And then cyanide poisoning. What do you guys have cyano kits? What have you guys been taught about using them? Great, that's what I wanted to hear. So basically, we can't ever prove on the scene, especially, that someone has been, poisoned with cyanide, and it really interferes with labs and all these other assessment things that happen once we're in the ICU. So I did just directly quote the American Burn Association, so I don't get faulted for anything on recommendations. But basically, we're not seeing them as much. We're not recommending that. Never have I been like, man, I wish that person got a cyano kit on the scene. So I just did want to recommend that. I'm trying. Okay, great, guys. Fluid resuscitation. So basically, when you arrive, you should follow your own protocols, right? Do your own protocols. But from the burn perspective and being the person that gets the patient later, this is the starting point that we want people to start at. But then really, if the consult process is happening the way it should, that means on the scene, people are communicating to the hospital they're going to, and then that hospital is already communicating to us saying, hey, we're about to get this burn patient, or hey, we just got this burn patient. Those are the fluids that should be running at that point, and it should always be LR. So you don't even need to worry about calculations or anything like that. Once again, do your protocols, but this is what's recommended. And then the second we're on the phone, so in the ED, maybe if we haven't been called yet, this is what things are going to start getting calculated on based on the size of the burn. But once again, in a perfect world, we don't even get to this step, and we're actually saying, our docs are saying what we want the fluids to get. So you have that, these are the fluids that are recommended initially. And then once you get to your secondary survey and you actually have a total body surface area and all of that, this would be the adjusted fluid rate based on the patient's actual injury. But our hope is that you're not even actually getting to this phase and we're recommending the fluids for that, because there's so much that goes into it. Do you think the 90-year-old lady can handle as much fluid as the 20-year-old guy? There's so much that happens other than just these numbers and formulas. It's not a catch-all for everybody. So, but these are follow whatever your protocols say, but those are our recommendations. And then we just want to remind people over resuscitation can be just as dangerous, right? And that's for those at-risk people who can't handle as much resuscitation. And then urine output. A big one for us is if they're 20%, we are hoping for a Foley catheter. If that doesn't happen in the emergency department, we try to put one in when they get to us. Sometimes people just straight refuse, like that chef guy refused. He had that concert, so We just want the urine output monitored. So even if there's no Foley, if they pee at any point in your care, please report that off. It just matters. It matters if they peed 300 before they even got to the hospital or in the emergency department or whatever. We want to know all the urine they had before they got to us. So I kind of just tried to summarize. If you take anything away from this presentation today, beyond all my silly stories and all of that, these are the things I want you guys to take away. So clean, warm, and dry. Use things like blankets, bear huggers, all of that. Never use ice. We care about the urine output. And then start fluids per your protocol, but please don't stress about it, because if consult process has happened the way it should, we will be on board soon, and that's our docs will be recommending what we want for fluids. IV access can be anywhere. I will be very proud of you if you get an IV through a full thickness burn. That is challenging, but we'll take any access to start. And then circumferential burns need frequent monitoring of pulses distal to those injuries. And this is the transfer criteria. This is posted all over, usually in emergency departments and on the website. This is what warrants a call to us, but a consult call can be made to us even if it's not in this criteria. And that is all I have for you. Because I just replaced Curtis and they have released me into the wild and I'm out of the four walls of the hospital, this is just a quick survey. If you get out your phone, whoa, whoa. If you hold up your phone, it's just like a quick 60-second survey to make sure I'm not traumatizing you guys or boring you guys out of your mind. And that's all I have.
Thank you.